Namaste. Namaste. All good?
Yes, madam. Everything is good.
Yeah.
Thank you,
Nice.
madam, for accepting our request to share your thoughts.
It's a pleasure.
Thank you, ma'am.
Want to know that? So good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. The topic for today's webinar is urinary tract infection and management. I would like to welcome all the participants and I request them to post their queries in the comment box so that we can have a short Q&A session at the end of the presentation. Ma'am, before going to session, I would like to take 1 minute of your time of explaining our Shield Connect webpage, ma'am. So our Shield Connect webpage has blogs where you can see where the experts like to share their research works and thoughts in our webpage, ma'am. So if you like to share any blogs, we'll be happy to publish in our website, ma'am. And we have a separate column for webinars. So all our webinars are conducted through our Shield Connect webpage, ma'am. So you can find the details of the upcoming webinars and the past webinars which is available in our website. And we have also a separate column for PCOS awareness where you can find short videos of doctors conveying their views about PCOS is available in our website. And we also have a separate column for our Shield, our leaders. So we have more than 220 leaders who are supporting our web page through our Shield Connect web page, ma'am, through their webinars and their contents related to our website. So thank you, ma'am. I would like to ask the participants to go through the website and make useful of it. And now it's time to introduce our speaker for the day, Dr. Lavanya Kiran ma'am. Lavanya Kiran ma'am has completed her MBBS OG and she has also have a fellowship in reproductive medicine and diploma in reproductive medicine from Germany. Currently, madam is the senior consultant and obstetrics and gynecology and reproductive medicine and robotic surgery IVF lab in charge at Narayana Health Hospitals, Bomasandra, Bangalore. Madam is a trained obstetrics ultrasound under Dr. Ramamurthy, Fetal Foundation of India, trained in laparoscopy and hysteroscopy surgeries, and trained in robotic surgery at Amrita Kochi. And Madam is also a member of various associations like Karnataka Indian Society for Assisted Reproduction, founder member of Karnataka chapter of Indian Fertility Society. And Madam has also received various awards like Foxy Award in 2019 and received Kempegowda Award for Samaj Seva 2018. So Madam has also published various journals in international journals. With this introduction, I welcome you, ma'am, and over to you, ma'am.
Thank you so much, sir, for introducing me. I'm so glad. I'm so glad to hear that you have such wonderful interest in academic. I think that gives a very great pleasure that a pharmaceutical company has taken such a wonderful initiative on an academic platform like this. It is so nice to know that you welcoming doctors to write their own blogs and educative sessions like this. I think I would congratulate Shield at the whole great initiative that you people have been taking.
Thank you, ma'am, and we need your support also, ma'am.
Yes, definitely. Let me get the talk for you. Just give me a moment, please. Can you see my slides? Not yet.
No, ma'am. Sanjay sir, you can just confirm with Madam sir. I think Madam has logged out.
Madam, it seems logged out. Just a minute.
Yes.
So is that visible now?
Yes, ma'am. It's visible.
Yes, ma'am. Yes, ma'am.
All right. All right. Good evening, everybody. I welcome you to this wonderful yet a very simple topic. But then, it is so important because it causes so much of agony on day-to-day life of every human being, I would say, be it a lady, be it a man, be it a child. I think this is really a very interesting topic and very important topic for all of us to learn. And again, thanks to Sheil for this wonderful initiative of getting all of us to connect to each other and learn in this pandemic. And I'm so happy that we can still all connect and educate ourselves and exchange knowledge. I think it's a wonderful thing that we'll be talking today. So what is this basic urinary tract infection is what we need to understand. Here, it is nothing but an infection which occurs when the bacteria invades the urinary tract, and so many times it can multiply so much you won't believe it is anything to do with the bladder, kidney, the urethra. Anything can be involved when we're talking about urinary tract infection. Did you even know that it is one of the second most common infection that can be acquired by anybody? And mostly this is more common in the female, where I would say it's like almost 10 times more compared to a male. And then at least 1 in 5 women will be getting a urinary tract infection at least once in a lifetime. But in women, it is more serious when compared to a man. Almost 6 to 10% per year suffer through this urinary tract infection. In pregnancy, again, almost 10% go through this. If a single catheterization happens, then their infection rate is almost to 3%, increases to 10 to 15% if it's in a debilitated patient. So always think twice when you want to empty your bladder. It could be before just a small procedure like either a DNC you want to do, or you want to do a hysteroscopy, or you want to do an EUA. It is best that you ask the patient to just pass urine before you put her into a lithotomy position. I think by simple steps like this that we are going to take, we are going to prevent a lot of problems because of this urinary tract infection. Like I told you, no, single catheterization itself is increasing our infection rate to almost 3% by just telling her pass urine before you put her into lithotomy instead of catheterizing her. Even before you oocyte pickup, I do a lot of infertility cases. So while we're putting up a patient for oocyte pickup or an embryo transfer, of course, we want a full bladder in an embryo transfer, especially when you're doing oocyte pickup, or you're suspecting something, you want to examine a small child under examination, under anesthesia and all. Such simple procedures, tell them pass urine. So it will prevent you from catheterizing a patient, and it can reduce your ratio. And like I mentioned, it's almost 10:1 when compared to a female to male ratio. But then again, in male, if somebody is less than 1 year, that baby, a male baby, is more prone. And if the man is more than 50 years, even they have higher incidences of UTI compared to the middle age group men. Lot of people, almost 10 to 13% of people have asymptomatic bacteria. That means the bacteria is there, but they do not end up showing any symptoms. Acute cystitis is seen in almost 4% of people. When it goes untreated, or the symptoms are ignored, or it can end up with a chronic UTI, almost acute pyelonephritis is going up to 2%. And incidence of bacteriuria in pregnant women will be slightly higher compared to a non-pregnant women. So whenever the pregnancy is progressing, even this pyelonephritis progression happens, and it is almost going to increase to 40%. And the rate of recurrence is also going to be very high if it goes untreated. there must be some predisposing factors. Now, that why only these 10 to 13% of female are getting this urinary tract infection? Why is the rest of the 85 to 90% not getting? What happens when somebody has a calculi, somebody is having a tumor, somebody's immunity is less, some extrinsic factor, especially when a lot of working women or even women at home do not drink enough water. All these people are predisposed to getting a urinary tract infection. If they have a UV reflux already present in them and they are having some neurological issue, for a incomplete voiding happens, or sometimes voluntarily also there's no proper bladder emptying happening, especially in diabetes, sickle cell, like I said, immunocompromised patients, bladder instrumentation, foreign body, any structural abnormalities, even sexual activity can also predispose to urinary tract infection. When we're talking about sexual activity, it is not per se the sexual activity which increases the UTI. It is just that any vaginal infection, the vagina and the urethra is so close by associated, vaginal infections can predispose to an UTI if not treated well in advance. And pregnancy, again, because the immunity is coming down, and because of the hormone variations, this person will be prone to UTI again. How do we diagnose this UTI? One is, of course, always remember there's no supplementation to any good history taking. If you talk to the patient properly, they will give you a typical history that they have a pain while passing urine or just before passing urine, or it aggravates just after passing urine. You can pick up nice, good, detailed history. You can pick up the symptoms and half the diagnosis is made. They'll tell you it's a pricking kind of a pain, or they have incomplete voiding of urine, or they have painful voiding. If you talk to them in detail, half your diagnosis is made. But then you have to rely on some diagnostic modality just on an OPD procedure basis. And if it's a smaller clinic places, you can definitely use the dipstick method where you can find out leukocyte esterase which is present. It is very accurate, especially when it is present more than 2+, you definitely can diagnose a UTI. Gram stain can be done where if there is one bacteria per high power field, you definitely know it is indicating a urinary tract infection. Microscopy of the urine can be done. That's the routine examination. Of course, the standard is urine culture and sensitivity. A lot of times you have noticed, I'm sure, that the urine routine says there's only 2 to 4 pus cells seen. But then, when you've taken a good history that the patient is typically showing a urinary tract infection, but then the urine routine says only 2 to 4 pus cells. So it's always a dilemma that do we have to ask them to do a urine culture sensitivity, or is it that we can go ahead and treat them with a symptomatic treatment? So like I said, there's no substitute to a good history. Take a good history. Tell them to give a urine routine and urine culture. I have seen at least 40 to 50% turn out to have a bacteria present on urine culture sensitivity, even if the routine says it's just 2 to 4 bacteria plus on a high power field. So always never miss to ask urine culture sensitivity when you know that this person is prone for urinary tract infection. This is how the dipstick can be done, where you can check out the specific gravity, the ketones, how much is the leukocyte esterase present. Like I said, when you know it comes as a purple color, that is 2+, you should be sure that yes, it is a urinary tract infection and you can go ahead and treat. Most of the times when we see it is the E. coli which is present, and can you believe it, 63 to 85% will have E. coli in the urine present. This is why I said if you think the history is showing that yes, she has a urinary tract infection, small pus cells done, you can start on a prophylactic antibiotics. I'll come to the treatment management, and prophylactic treatment can help the patient prevent in a long term so that she doesn't have to end up with pyelonephritis or any other gross or chronic urinary tract infection, which can hinder her life. And then quality of a lifestyle is definitely going to reduce. And you can see the agony of these patients when they keep coming back to you. They are so fed up. They say, madam, what is this? Every month on month I'm coming. What do? I am drinking enough water. So what is it that we can do? So you need to find out what kind of bacteria is present, so that if it's an E. coli, what is the sensitivity, which medication works best on them needs to be done. That is why the urine culture sensitivity plays a very high role. Almost 15% of them can have staphylococcus, and then we can see that group B streptococci is also very common. Klebsiella pneumonia is also very common, and aureus is there in almost 8% of these patients. Like I said, very typical symptom is dysuria. Frequency will be high, urgency will be high. Nocturia, when a lot of, I would say this is a trick in taking the history. A lot of patients, now, it's very difficult to get a good history from them. So when you ask them, it sounds more like a urinary tract infection. They're like, oh no, I always drink a lot of water, doctor. I don't think it is. Are you going to urine more frequently when you ask a question? I'm sure all of you have gone through this scenario where they say, I drink enough water. This is why I go to the loo more frequently, is what they would immediately would follow your question when you say, are you using the loo more frequently? So the best time to ask them at that point is, how many times do you wake up in the night to pass urine? So because when you say you're definitely going more times, they will give you an answer. I'm drinking more water. This is why I'm going to the loo more frequently. So you ask them, how many times do you wake up in the night? That will tell you, yes, definitely her, it is a urinary tract infection, because she will say, I am getting up 2 times, 3 times, or 4 times in the night, which is not generally the case. All right. Suprapubic pain is another typical symptom. It can be associated with the back pain. Quite a lot of times they say blood is passing through the urine, hematuria, cloudy urine, or there is no urine at all. So all such symptoms when you ask, this is why I said typical good history will help us diagnose half these things. If we are talking about babies or much younger girls, we can see that they are lethargic, poor feeding happens in babies, fever, evening chills, very typical symptom in any category of patients. If it is babies, sometimes you can see there is associated with vomiting, diarrhea. That strong smell of the urine is always there in babies, and sometimes they're hypothermic as well. In elderly patients, we have to be very careful in the symptoms. Other than all the dysuria, back pain I mentioned, they can have temperature, hypothermia can also be there, high degree of temperatures can be there, weakness, malaise is very common, sometimes associated with vomiting, hypotension, confusion, because a lot of dehydration happens with them, frequent urination keeps happening, urine retention can be there, causing a lot of pain, and then all these symptoms can cause into vasovagal as well. So please remember, good symptoms and signs is very, very important, though they will not tell us, is it an upper tract infection or a lower tract infection, where we'll have to do more clinical research on this, go into a deeper perspective and see. Never miss on checking a vagina when somebody comes with recurrent UTIs. It's always best in a female patient to check the vagina once to see, is there any vaginal infection? How is the cervix looking? Very important, like I mentioned, any vaginal infection can be a provocating factor or predisposing factor for a urinary tract infection. So please treat it simultaneously so that this person doesn't have to keep going through a recurrent urinary tract infections. Most of the common times, whenever it is a recurrent UTI, or they can go into asymptomatic bacteriuria. So you need to pick up of the slightest of the symptoms. Whenever you're examining, if you see this tenderness, so please make sure that you rule out, and then in this order, you can prevent them from going into cystitis or acute pyelonephritis phase if treated well in advance, and picking it up early is very important. So you can prevent them from going into chronic asymptomatic phase. So what is it that we are talking when somebody is asymptomatic? That means they do not have any symptoms. And according to the Infectious Disease Society of America, they say bacterial monoculture, if the quantity of more than 10 is to the power of 5 colony units per ml in 2 consecutive midstreams. So it's very important that you educate the patients of how to collect. You tell them you can wash, dab the vaginal area or dab the genital area, just dab, not rub. And then once you pass the first stream, catch the urine in the wide mouth container in the midstream, not the starting, not the ending. I know it's very difficult, but then you need to educate the patients, because most of the times you can see that the reports will start saying mixed flora. And it's very irritating for the patient also to come back and give a repeat sample. So make sure every time your patient is asked to give a urine routine, urine culture sensitivity, you talk to them. Your nurse instructs the patient of how to give the urine, and that would be giving you a better result than getting a mixed flora and calling back the patient to tell them, please give another sample. So like I said, even single catheterization is prone to get all these bacteriuria, and they end up becoming more asymptomatic bacteriuria, because you will say, you just finished a procedure, this is why you have a suprapubic pain. So do not ignore when they come back post procedure, because you would have catheterized and they ending up in a asymptomatic bacteriuria. So it is very important that you listen to their complaints, pick it up and start treating them very well, and that is when we prevent them. So screening is very important whenever you pick it up, and especially in pregnancy, make sure whenever they come, that is the early pregnancy, you screen the urine. Prenatal visits, even in the first trimester, urine routine has to be done so that you can pick up, because a lot of times urinary infections in pregnancy can lead into a lot of complications in the pregnancy, leading into even preterm deliveries. And I do have slides on how it affects a pregnancy and the babies. So if it's not treated, these patients, almost from asymptomatic, 40% can end up with chronic issues, and they become symptomatic, and it persists to go through the pregnancy, leading into even acute cystitis, where it can affect in a very bad way, and then it can lead into ascending infections leading into pyelonephritis and chronic kidney issues. All these things will end up having. So pick up symptoms whenever they say they have dysuria, frequency is increased, urgency is there, suprapubic pain, even though they are asymptomatic. They don't have to have fever and chills all the time. Hematuria, lower urinary tract infection with pyuria. All these things will also help us diagnose chlamydia, and then this will help us diagnose acute cystitis, and treated well in advance, we can prevent them going into pyelonephritis status, where a lot of medical complications in pregnancy can be prevented. These people, if undiagnosed, can end up in septic shocks during pregnancy, and a lot of times kidney damages are very, very, very common. Quite a few of them end up coming to the clinic saying they have fever, chills, and this is why I said do not ignore. Don't say, oh, it must be COVID, and brush them off. You still have urinary tract infection. You still have a lot of other flu kind of symptoms that you need to talk to the patients when they say fever, chills. Talk to them. They will give you the typical suprapubic pain, increases on passing urine, or at the end of the passing urine, they have pain. Or like I said, ask them how many times are they waking up in the night to find out, is it a urinary tract infection? And lumbar pain is usually associated with this. And nausea, vomiting can be one of the symptoms, and costovertebral angle tenderness is very important. Examining the patient is again very important to pick up the signs from them. So ask them to turn around. If she's advanced in pregnancy, put them on the lateral position, check on the costovertebral angle to see if there's a tenderness. This will help you pick up pyelonephritis as well. So very important that you check. And if it ends up as a pyelonephritis, almost 70 to 80% of the urine will end up showing E. coli. Like I mentioned, this is one of the common bacteria that is present. The rest, like I mentioned, Klebsiella can be there, Streptococcus aureus can be there, Enterobacteria, all falling into 5 to 8%, leading into pyelonephritis. Again, of course, renal biopsy is the only modality to diagnose acute pyelonephritis, but then you can pick up, and we don't want our pregnant women to go through all these biopsies. So pick the symptoms early so that you can treat your patients much earlier, and you can identify if they're recurrent, prone for urinary tract infections. And if you treat, they don't have to end up with pyelonephritis, nor they need a renal biopsy. So picking them on time is very important. So a combination of symptoms, blood test, inflammatory markers, renal function test, urine culture, like I mentioned, culture and sensitivity will pick up urinary tract infections at the earliest. People who have all these things can also have, or increased prone, have alveolar injuries, and then it can lead into acute ARDS, hemolysis, anemia, bacteremia, renal dysfunctions can also end up being there. Like I mentioned, if she's pregnant, you know what, recurrent infections leading into acute pyelonephritis. Even forget acute pyelonephritis, recurrent UTI in pregnancy, we've all seen that it leads to an IUGR baby, small babies, low birth weight babies, preterm labor, preeclampsia, chorioamnitis, postpartum endometritis, even chorioamnitis leading into PPH also can be seen. So these things can be a real complications if we do not pick them on a regular antenatal check. So make sure you ask your patients to do urine routine, and come back even while you're evaluating natally do it, in the first trimester you do it. Make it a habit to ask them whenever their routine visits are there, to just do a urine routine at least, and see if there are more than 4 to 6 puzzles. If there's no symptoms, ask them. But if they have a symptom, even if it is 2 to 4 bacteria present per high power field, make sure you ask for a urinary culture sensitivity if they have symptoms. If no symptoms, keep 4 to 6 on the high power field to ask for a urine culture sensitivity. We have seen it leads to chorioamnitis, lot of times leading into appendicitis, placental abruptio, leiomyoma infections can be there. There have been babies who can have low birth weight because of mother having chronic UTI. You can see this babies ending up with septicemia on the NICU, and for 48 hours later, postnatal day 2, you have your pediatricians calling, did the mother have any infections in pregnancy? Because it starts seeing in the baby. They pick up at that time, premature babies. It can even lead into delayed milestones, mental retardation. This can be a bad scenario when the obstetrician does not pick up a simple UTI. Like I said, that's why I said it is a simple disease, but it can be a nightmare. Chronicity is quite bad, leading into a lot of disturbances. So picking it up and treating it at the right time is very important. Even prenatal mortalities are very common. But how do we take care of this simple complaint that our patients come? So a lot of times you say, yes, it is UTI. You don't drink water. This is why you're getting it again. If we shoo them off, is that the right way to do it? Because we know what all complications are happening. We need to treat them aggressively, even though we think it is a simple treatment. So aggressive modality of treatment is very important. Picking up the asymptomatic bacteria is very important. You can even go with the single doses where you can use amox or ampicillin, 3 grams, 2 grams respectively. Cephalosporins can be done, nitrofurantoin can be done, or you can put them for a 3-day course of amox or ampicillin, ciprofloxacin, levofloxacin can be used, where you tell them, look, your urine routine says 2 to 4 puzzles, but you are having symptoms, so it is an asymptomatic bacteriuria, or you have mild pain, and then you can tell them to take a 3-day course, and then you can call them back. By then you can get your urine culture sensitivity and go ahead. So all pregnant women with asymptomatic bacteria should be having a periodic screening. That's why I said always make sure every visit they at least do a urine routine and come back. And if urine routine shows a lot of puzzles, ask them for culture sensitivity. Once you've treated them, ask for a repeat culture to make sure there's no infection there, and repeat it again in a month's time, which is very, very, very important. If it is a persistent recurrent bacteriuria, I think it is worthwhile to put them in an antibiotic like nitrofurantoin, where you can continue it on a low dose for a very long time. If you see that persistent urine culture shows that the bacteria is there in spite of treating her with a single course of antibiotic, if it doesn't get better, make sure you put her on a low dose for a longer duration of time. And postpartum, make sure a urologist is evaluated, and then the infection gets treated, and never miss doing a vaginal examination for her. Do a perspiculum examination. If this associated vaginal infections, treat it, very important. Of course, you have to talk to her about good fluid intake in any forms. It can be water, your vitamin C rich fluids can be there. Imagine this urine, we have to alkalize. So use the alkalizing agents, which is very, very important. Cranberry juice, I have seen it is a good choice. So you can educate your patients on taking a cranberry juice, but for everybody, it is not easy to access a cranberry juice or go and pick up cranberries and make a juice and drink. So we do have a lot of medications in the market now available very easily. So the mixtures of cranberry is available. So you can put this, which is very safe in pregnancy as well. So you can use these medications, which is available in the market, because they change the urine so into alkalizing way and reduces the symptoms of these patients. Symptoms are so much better, and even the urinary tract infection can come down. And if it is very acute, you have to admit them, you have to give them IV fluids, and then do a culture sensitivity, rule out other infections as well. Do a blood culture if it is required. Don't always keep thinking, oh, it has to be urinary infection. Check her serum creatinine, check her on the electrolytes, make sure you're not missing out anything. Check the input and the output chart. If required, then you have no choice. If you're not getting a good input, you have to catheterize the patient. So make sure that she's throwing enough urine of at least 35 to 50 ml per hour, and make sure she is well hydrated, even if it requires a intravenous fluid administration. Like I mentioned, ARDS is very common, especially when it is acute pyelonephritis if she's ending up with. So rule out ARDS. So make sure that the abdomen is covered with the shield, and then you take an X-ray. You can go into intravenous administration of the biotics which is needed. The therapy needs to be started on the right dosing. Hematology and the biochemistry study has to be done. And if she remains afebrile with your antibiotic treatment over 48 hours, you can discharge her and then consider following her up on an OPD basis, and then continue the oral administration of the same antibiotics. But make sure once she goes home, when she comes back at the end of 2 weeks, you ask her to come back to urine culture to make sure if everything is all right or not. NSIDs work definitely well. You have to make sure that if this woman is confined to bed when you're admitting her, she's not mobile much because you have catheterized her because you wanted an input-output chart. So make sure you put her on a TET stockings, or you ask her to ambulate in the bed itself of all the exercises. Maybe you'll have to end up giving her a low molecular weight heparin also required. Tocolysis plays a very important role. Like I said, urinary tract infections can lead into preterm deliveries, and preterm babies have a lot of mortality and morbidity associated. So very important that you pick up the UTI on time and treat it very well. And if you are suspecting, yes, this pregnancy is going to end up with a preterm delivery, make sure antenatal steroids are given, fetal lung maturity is obtained, in order that you are well prepared to handle this threatened preterm. If possible, prevent it. Otherwise, get geared up to make sure you deliver a healthy baby and send home this mother with a good bundle of joy that you have. So if you're dealing with a mild or a moderate acute pyelonephritis, we have good choices of ceftriaxone, amoxicillin, cefepime, which can be used at 1 gram 24 hours. If it is severe to acute, then you have piperacin, tazobactam, meropenem, all can be used because you have no choice. That is the way we have to go. But then we have quite a lot of medications like clindamycin, nitrofurantoin, ampicillin, simple of the drugs, cephalosporins, azithromycin can be used, and they all fall in the FDA category B. And then second option comes your ciprofloxacin, levofloxacin, clarithromycin, amikacin, gentamicin, all falls in C or D category. So your first options can be amox or nitrofurantoin, clindamycin, azithromycin. These can be your first choices. And if you have to end up giving them higher antibiotics, like I said, IV antibiotics you have to prefer. Of course, you can give them piperacillin and all those things if you're suspecting a very high fever. Now we have a new kid on the block, the new antibiotics, especially in the urinary tract infection. I have seen a great wonders in my patients whenever I use fosfomycin. It is just a single dose. I give it to them and they come with a typical symptom, and I know it is very safe in the second and the third trimester of pregnancy. So it's a single dose. It's a sachet of 3 grams. You have wonderful companies like all the Shield coming up with fosfomycin, where you give them a single sachet. You're waiting for a urine culture reports to come, and you know that she's having typical symptoms. I tell them, take this sachet, and you have to remember it very well while you're giving her this sachet. Preferably, she takes it in the night, because once she takes this sachet, she should not be passing urine for the next 3 to 4 hours. It's a very important instruction, because the sachet per sachet also the cost will be quite high, around anywhere between 250 to 350 to 400 is the cost of one single sachet. So while you're giving this sachet to the lady, you need to tell her. What I always tell my patients is use it in the night, because in the day, the more you say don't do this, they tend to do that more. So when you tell them don't pass urine, they feel the urge more. So tell them in the night, post your dinner, pass urine, take a small tumbler of water, mix it, make it like a juice, drink it and go to sleep. Very important to tell them to pass urine and mix it in a small tumbler of water, because the bigger tumbler they take, they're going to go pass urine in an hour or two. So all your money is down the drain. So you have to instruct them, telling them small tumbler is very important, because they need to hold on their urine for the next 3 to 4 hours. And that is how this sachet works. And I really like this fosfomycin, because by the time they get their culture sensitivity, you can see that quite a lot of them are already symptomatically better. And if the culture picks up that the fosfomycin is acting well, you can just ask her to repeat another dose for her if required, or if she's already symptomatic better, then you don't have to put her on any antibiotics, and works wonder because it is just a very single dose. And I really like this product really well. And of course, it's a category B drug. Like I mentioned, go ahead and use it in the second or the third trimester. And if it is an acute pyelonephritis and if it is not responding at all, like I said, IV fluids is very important. Considering the antibiotic therapy is very important. Wait for your culture sensitivity, change your antibiotics. Like I said, start with ampicillin or nitrofurantoin or piptas if required, piperacin, which works very well. And then depending on your culture sensitivity, you can pick up. And also find out if there's any persistent infection leading into pyelonephritis or abnormal urethra, pyelocalcial dilatation, intrarenal or perirenal abscess, nephrolithiasis. All these things also have to be ruled out if somebody is coming with persistent infections. And yes, if it is persistent infection, you have to make sure the kidneys are evaluated in an ultrasound, or one shot of intravenous pyelogram can be done. MRI can be done for these people, because if she's having so much of symptoms, then you cannot help at all. You can see a lot of patients that there's no relief at all. They suffer with the pain. Then we have no choice but to place a double J stent, a urethral stent. They can do it. And percutaneous nephrostomies will be done. And if the stones are seen, and we have no choice but to go ahead and remove the stones is what we have to do. So you can do the low count bacteria, even in the negative cultures can be done, where the biofilm can be used, intracellular bacterial colonies can be seen, and uropathogenic E. coli can be detected. And this, if it goes undetected in a normal urine culture, like I said, is very important. And sometimes they fail to explain why these things are happening. That is why we can know that it can be because of the bladder pain syndromes. Interstitial cystitis can be explained in all these undiagnosed bacteriurias. So here, when we are doing a culture, what happens, you can see that there is a sloughing, there is all these bacteria which is invading, and that is why they happen to bind, and then you see these biofilms can be there. Then the recurrence keeps happening because the binding is there and the invasion happens. So this is why when you use this nitrofurantoin or a Canberry extract, it prevents the binding from happening. And so if binding is prevented, again, the invasion is also prevented, recurrence comes down. So a combination of a good antibiotic like a nitrofurantoin, and then you can tell them, especially in pregnancy, you can't keep putting them in antibiotics. Even the patient is fearful, whatever, and you know it is all a category B FDA drug. So you cannot keep using an antibiotic. So tell them, educate them, a Canberry juice extract or a concentrated equivalent is very important, which will help them prevent recurrent UTIs along with your water. And this can become a part of their daily routine process, which they can use it in water and keep drinking it like a juice, which is hydrating. And you know the summer is around. So prophylactically using a Canberry extract concentrates from all the companies can really help them prevent UTIs as well. Forget recurrence, even the simple UTI can be prevented. Local hygiene education is very, very important. Tell them, because like I said, summer is around, the fungal infections, tight undergarments, nylon undergarments, educate them on all these things. If they're coming with white discharge, like I said, do not miss on examining the vagina. Make sure you examine, treat the local infection. If there's a candidiasis, any suspect of a bacteria, take a culture swab of the vagina as well and treat them accordingly. So sexual activity in the women can also lead into infections. So any conventional treatment, whenever they're having a burning maturation, we need to use the alkalizer. If there's a pain, it can be relieved by a flaxovate. Recurrence by a Canberry, which is always there. But then I have seen that ursodeoxycholic acid works very well in pain because it is a very good anti-inflammatory analgesic. So they had a good rapid relief for pain. And then burning maturation, you can use a potassium magnesium citrate where the pH can be acidified and then alkalize the urine. And then Canberry extract, like I said, it's an anti-adherent property. That is why the binding is not there, and then the invasion is not there, and that is how it prevents recurrence as well, because it is anti-adherent property in the Canberry extracts. And D-mannose has an anti-adherent property, again preventing from recurrences. A good company which has all these extracts, the Canberry extract, you can ask your patient to take it, especially when you know that these people are going to go in for recurrent UTIs. I hope this talk is going to enlighten all of you and help prevent our women to have a healthy pregnancy, a comfortable pregnancy, so that we prevent them ending up with this small little infection of urinary tract infections, which can actually be devastating in the pregnancy. So let us all wish that our women are all healthy, be it pregnancy or without pregnancy, because we all know urinary tract infections can be very devastating. All they have to do is simple. These extracts in a combination can save and make all these women's life and the men's life as well more comfortable. Thank you so much.
Thank you, ma'am. Thank you very much for that wonderful presentation, ma'am. Hope the participants found this webinar very useful. Ma'am, if you allow us, then I will read out the questions.
Yes, please go ahead.
We have a question like whether this fopsomycin is effective against Pseudomonas species, ma'am.
Yes, it works quite well. You can try it. Like I said, while you're waiting for, you can start it while you ask your patient when they come to your OPD. What I always do is tell them you're getting your urine culture sensitivity. You need to remember it's coming at the end of 48 to 72 hours. So that's a long time with a lot of frustration of the patient going through a lot of pain. So it's just a single dose, which is very good. This is why I said let them take it, because it has got all these extract, prevents them from a lot of symptoms. By the time they come back with your urine culture sensitivity, there is a little difference in their symptoms. Depending on your culture sensitivity, you can change the antibiotic according to the sensitivity of the culture.
Thank you, ma'am. And we have the next question like what will be the treatment for UTI infection in male, that is particularly in older ages, ma'am? Whether any precautions necessary in?
Yes. Ask again for them. Incomplete voiding, I think, is very, very common in an elderly age group. They have to be evaluated for benign prostatic hypertrophy. So, an ultrasound, like I said, KUB evaluation needs to be done. So, a lot of these older men will be suffering with prostatitis and infection. So, if you again talk to them in detail history, they can give you a good history of all the pus which comes out from the penis. So, local hygiene is very important. So you need to educate them. And sometimes because of the BPH, again, dribbling happens. This itself will lead into a lot of infection. So getting them to attend a urologist, examine them, ask for a KUB. All these people needs to be evaluated. Ask for a routine urine culture on regular basis will work. And like I mentioned, these symptoms of fosfomycin, and especially all the Canberry extracts, like I said, works very wonderfully well, because there is a change in the pH of the urine as well. And it is not an antibiotic, all the Canberry extract, the menace that is used. So they can use it for a little longer time to find a good relief, other than treating the pathology which is present.
Thank you, ma'am. And we have another question like you have said about this. Ma'am, am I
No, you're not audible to me. Sorry.
now am I audible,
Yeah,
ma'am?
yeah.
Yeah, ma'am. You are speaking about this bacterial infection during pregnancy, ma'am. What should be the treatment if there is any fungal chances of fungal infections, ma'am?
See what happens. Women, lot of vaginal infections are very common, especially if they're sexually active. And like I said, in pregnancy, the immunity comes down. So when you examine them in the vagina, you can see a lot of white discharge. So you can give them the local treatment, like if it's a candid infection, you can treat accordingly. If you're suspecting and there's a color change in the discharge of the vagina, you can always end up taking a culture sensitivity and see what works better. So always treating the vaginal infection is also very, very important, and educating the pregnant women about good water intake is again very important.
Ma'am, how to treat a female who is trying to conceive, ma'am? Who is trying to conceive and she has UTI, ma'am? What should be the treatment? Whether she can go for any antibiotics or any
Yes,
natural antibiotics
definitely.
like probiotics, ma'am?
Yes, definitely. I think there is a good role for such patients there. So where they can be using probiotics, like I said, all these Canberry extracts, which is being used, I think works very wonderfully well for them. So that psychologically also they're comfortable, that you're not putting them on a long-term antibiotics. And you can definitely see, which I have seen in a lot of my patients, where they are so much more comfortable, or the chance of the recurrence comes down. So you can put them on all the Canberry extracts and the combinations that is available. So all these things, when used and you educate them about the local hygiene and these extracts, you can definitely go ahead with your ovulation induction and treat them. And evaluating your partner also becomes very, very important, I would say. So evaluate them, because a lot of sexual activity, when it is happening, so it is not the sexual activity which is increasing, but the infection in the partner. What happens when they ejaculate, the semen itself can be a provocating factor, and that is why the female partner ends up having a lot of issues. And again, evaluating for a diabetes is also very important. So simultaneous medical evaluations needs to be done. If there's any reflux present, diabetes is again very common. So doing a thorough medical checkup is again important to rule out if there's anything else associated or aggravating factors.
Thank you, ma'am. And we have one last question, ma'am. Like, what will be the drug of choice in post-menopausal women with UTI?
See, UTI in postmenopausal again depends on what your urine routine and culture says. So, if the urine routine says something or the culture is picking up something, you go by that. But if we are talking about a prophylactic treatment, so I'm assuming that you're talking, because all of us know if a culture sensitivity picks up in bacteria and it shows the sensitivity, we are going by that. So I'm assuming the question is to go as per asymptomatic bacteria, or the culture doesn't show something and then she's coming back again and again. Please remember, one, again, putting all the combinations of your Canberry extract works wonderfully well. Again, very important that you rule out vaginitis. In these menopausal women, your isoflavones play a very important role here. All the prophylactic medications is very important. So again, you have to examine her, because they can be having atrophic vaginitis. So again, examining them very well, giving them a lot of symptomatic treatment works wonderfully well. And there's also vaginal regeneration, because when the vagina becomes atrophic, these things work very well for them as well. And you have a lot of isoflavones and a lot of estrogen extracts, which is not a hormonal this thing, which works very well in menopausal women, like the estrogen, which is present, that I use for quite a lot of my patients, and they do very well in symptomatic, because they come back and say a lot of burning sensation has come down for them. So that drug also works very well for the patients as well.
Yeah, ma'am. Thank you, ma'am. Thank
Thank you.
you for that wonderful presentation, ma'am. Ma'am, I don't find any other questions in the chat box. So if you allow us, then we can end the webinar for today, ma'am.
Sure. Yeah, please go ahead.
Thank you, ma'am. Thank you very much for spending your valuable time with us, ma'am, and keep supporting us for further webinars in futures also, ma'am.
Thank you so much. Thank you. It was a pleasure for the evening.
On behalf of Shield Healthcare, I would like to thank all the participants for their patient listening and for spending the time with us.
Thank you.
Yeah, ma'am. Thank you, ma'am.
Thanks a lot, madam. It's all privilege. Thank you.